everyone. My name is Eszter Gulyás, and I would like to present my PhD topic, which is antimicrobial therapeutic drug monitoring in critically ill patients by a clinical pharmacist. I'm working as a pharmacist at the University Pharmacy Department of Pharmacy Administration in the last 6 years, and I became interested in clinical pharmacy of intensive care, and my vision is to be a bridge between the clinicians, the laboratory medicine experts, and the clinical pharmacists. And my mission is to become an expert in the utilization of antibiotic therapy drug monitoring results. I have 2 ongoing projects. Both is related to therapeutic drug monitoring, and I would like to present them. First is guiding the administration of beta-lactams with therapeutic drug monitoring improves clinical outcomes in critically ill patients. The method which was used is systematic review and meta-analysis. The background of this topic is that around 70% of the critically ill patients who are admitted to the intensive care units receives antibiotics, and the beta-lactams are the most frequently prescribed among them. And the pharmacokinetics of these drugs varies considerably in this patient population, causing uncertainty in dosing. And therapeutic drug monitoring is an essential tool for decision making and for making the antibiotic dosing optimal. But we don't know its added value and the effect on the clinical outcomes, so we would like to evaluate these outcomes and results. The question what we phrased was that is TDM-guided beta-lactam antibiotic therapy is more effective than standard of care therapy. So we compared the TDM-guided adjustment of beta-lactams to standard of care therapy, where it means that the antibiotics are dosed on label as it is in the pharmacy SPC of each drug. Our primary outcome was clinical cure, and we investigated on several outcomes as secondary outcomes. Before I move on with my results, I would like to highlight that one meta-analysis was released in this year in our topic in clinical infectious diseases with the same P-code, the same evaluation. So we had to revise our study, and because this search was the most updated, and then we decided that we have to renew our search. So in the middle of October, I was pushed back to the start line, but we started again, and now we have almost everything done. So as I mentioned, we did the search again with almost the same outcomes. 8 articles found to be eligible. And then I would like to present the results. We established 3 levels related to the connection to or the impact related to TDM and the outcome. So the level 1 and the primary outcome was clinical cure. Wherever we could, we did a subgroup analysis thanks to our statisticians. So the RCTs and the observational studies were analyzed separately to see the tendency between each results and the methodology, the observationals and the RCTs. Here you can see the clinical cure, which seems to be very much significant. It means that in the TDM-guided group, the odds for clinical cure is 2 times higher than in the standard of care group. The secondary outcome was microbiological eradication. Here we also did a subgroup analysis, and it is also statistically and clinically relevant and significant data. It also shows that almost 2 times higher the odds in the TDM group compared to the standard of care group. And the first level outcome was target attainment. It means whether we can reach the minimum inhibitory concentration during a dosing interval in the blood, and it means that almost 2 times higher in the TDM group that compared to the standard of care group, but this result was not statistically significant, but clinically is very relevant data. I would like to move on with the level 2 and level 3 outcomes. First is treatment failure, which was the complementary of clinical cure. So those cases who were not considered clinical cure were defined as treatment failure. And this data also shows that it is more common in the control group, and it's also statistically significant data what we get. ICU mortality and length of ICU stay were our secondary and third level results, which means that these results didn't connected so strictly to TDM as the previous outcomes, and these data didn't show any statistical or clinically relevant data. As for conclusion, I would like to say that TDM-guided therapy increases clinical cure and microbiological eradication, and also it decreases treatment failure. The patient population is homogeneous because the critically ill patients are very we need homogeneous patient populations because the critically ill patients are a heterogeneous patient population, and we would like to evaluate more standardized protocols and more exact standardized clinical endpoints would be desirable. For clinical implication, TDM-guided administration of beta-lactams should be facilitated in intensive care, and also RCTs are needed with greater sample size, and in the future we would like to, it would be very nice if we could investigate on the cost effectiveness of TDM as well. Our strengths were that we had quantitative outcomes, we could do subgroup analysis for RCTs and observational studies, and the endpoints bear direct relevance to clinical decision making. Our limitations were the small sample sizes, the heterogeneous population, and some kind of moderate risk of bias. This is the status of my manuscript. As I mentioned earlier, I started to, again, this manuscript, but we are almost ready with the manuscript with my supervisors. We changed our target journal to intensive care medicine, as also Professor Molnar advised earlier, that this journal doubled or even tripled its impact factor in the last year. So the focus was on the first project, but also the second project, the clinical evaluation of the pharmacokinetics-based guidance of colistin therapy is still ongoing. This is my clinical project, and its background is that this molecule colistin was discovered decades ago, but it was abandoned because its narrow therapeutic index and its nephrotoxicity. But due to the emergence of the gram-negative superbugs like Pseudomonas aeruginosa, it was also implemented in daily therapy at intensive care, but we don't know its pharmacokinetics in these critically ill patients. So at the laboratory medicine department, my supervisors and his team, we developed our new methods to evaluate colistin. And there is, it belongs to the group of polymyxins, and we can measure polymyxin A and B together. And this drug is a product. We give the patients colistin methanesulfonate, which transfers to colistin in the blood. It has a wide distribution and 50% protein binding, and it eliminates with glomerular filtration. This is our multidisciplinary framework, what we established, and in the laboratory medicine, they are doing the spectrometrical part of the study. As a clinical pharmacist, I'm implementing the results and discuss it with the clinical intensive care clinician, and then we adjust the dose for patients. We have now 14 patients, and the results are under extraction for these projects. So with these two ongoing projects, I would like to reach my goals, and I would like to thank you for your attention.
Thank you, Eszter, for your presentation. I would like to ask a question regarding your first project. You said that there is an already published article. Did you or are you evaluated this article? Was it well performed? And are your investigation can add a value upon this?
Thank you, István, very much for your question. Yes, we did an analysis on this meta-analysis as well, and it seems that they made several numerical and methodological kind of mistakes. It's under revision with my supervisors how to interpret this and how to communicate these results. We were not able to, we have the same eligible articles, but as I mentioned, we have different aspects.
I just have a comment. I'm sorry to say anything because I promised myself not to say during the progress report. This is the first time that I say something in the 4 days, but I have to. The only issue is how you mentioned that something was published and you completely did something differently because somebody published something, as you referred during your presentation. I must say that it's a very clear message not to do this. Just because somebody doing the same research and publishing something, it's not an indication of changing anything. The question is whether your question was good or not. As you could see, plenty of publications coming out on the same topic. Of course, you lost to be the first one, but to be the second, third, fourth, and also if you look at the grade assessment, you can give a assessment only in a guideline if at least 2 meta-analyses showing exactly the same result. Just I would like to say, because know your publications come out, don't do or don't afraid of if something came out. Of course, you will not publish in a 20 impact journal. We had the same in an ERCP and combined therapy preventing the ERCP. Just 4 days before the article came out, and Lancet Gastroenterology, for that reason, didn't publish it. Pancreatology published it, and within a year, it got 9 citations, which is quite high in the field. The other paper got 21 citations. They were 5 days earlier, but do not change the way how you publish your questions, your anything, just because something come out. It's very important, because many articles will come out now to go home with the message. You have to concentrate on your paper and not on what the others published.
Thank you. May I have just,
sure,
maybe
sure.
I presented something misunderstanding, but we didn't change our question or our search key. We just renew it. We did the search again. Okay, sorry, then I'm sorry.
I'd like to ask regarding your second project, the pharmacokinetic monitoring. In psychiatry, it's also difficult to monitoring the effect of a different drug. And my question is just about what's the methodology of the monitoring? I mean, regarding the half-time of the medicine when you take the blood, how do you interpret if, for example, the level of the drug is low, I mean the blood level, but the symptom is gone. So can you please tell me a little bit more about this?
Yes, thank you very much. Right now we are not able to do a real-time adjustment. It means that we have some kind of lack of time when we can adjust the dosages. So we do kind of retrospective study. So we give the samples to the laboratory medicine. They do the spectrometry on this, and then we see which kind of concentrations we found in the blood, and then we compare it to the MIC, and then we evaluate the results, how to modify the dosage, but it's something what we will do in the future, more or less. No, we are establishing the protocol because there is no protocol for colistin. That's kind of a novelty what we do in the country. Yeah, they do it in abroad, but not here in Hungary.